Hello, everyone, and welcome to today's webinar. I would like to remind you that this conference is being recorded. At this time, all participants are in a listen-only mode. For those connected by telephone requiring operator assistance during the call, please press *0. Web participants requiring support should use the chat feature on your screen. I would like to now turn the meeting over to your moderator today, Marianne Darpino, Senior Director, Patient Safety Improvement and Capability Building at Canadian Patient Safety Institute. You may begin.
Thank you, and good afternoon, and welcome everyone. On behalf of the Canadian Foundation for Healthcare Improvement and the Canadian Patient Safety Institute, I'm delighted to be your host for the next 90 minutes as we discuss family presence in long-term care. I would like to open by acknowledging the land for which I'm speaking from today. Bolton Caledon in Ontario is located on the traditional territory of many nations, including Kisun, the Huron-Wendat, the Adirondack, the Mississaugas of the Credit, the Anishinaabeg, and the Haudenosaunee people. Like many of you on the call today, I think we know all too well some of the alarming statistics and certainly devastating situations affecting seniors that have occurred as a result of the pandemic. The COVID-19 pandemic has profoundly impacted the health and care of older adults, and particularly devastating consequences for those residing in long-term care homes, retirement homes, and assisted living homes. Canada has, in fact, a higher reported national proportion of COVID-19 deaths for long-term care residents than any other country worldwide, with more than 80% of total COVID-19-related deaths occurring in long-term care homes. In these early days of the pandemic, we do recognize that decisions were made with the intention to protect residents and family caregivers. However, we are learning together this has further created severe impacts on the quality of life for seniors, their families, caregivers, and healthcare providers. We know that provinces and territories are rapidly implementing interventions to improve long-term care pandemic preparedness and mitigate a repeat of the first wave. To inform the implementation of interventions with both potential for impact, we conducted a rapid environmental scan that included 40 key informant interviews, certainly with family partners in care and health system leaders, to explicitly identify promising practices and policy options that can be taken now to ensure that long-term care homes are better prepared for a potential second wave of COVID-19. The Canadian Patient Safety Institute and the Canadian Foundation for Healthcare Improvement has launched a new program, Long-Term Care Plus, Acting on Pandemic Learning Together. The program is based on research captured in a new report, Reimagining Care for Older Adults, and focuses on those promising practices that we will touch on today that have the potential to reduce the risk of future outbreaks or mitigate their effects. The team at CFHI and CPSI will post resources and links to the program and other key reports that we're speaking from, and I will also touch on this towards the end of the webinar. As we know, none of this would be possible without the support of so many committed individuals passionate about making a difference to the quality and safety of care for seniors. And so I am absolutely delighted to introduce an extraordinary panel of presenters who bring such dynamic and enlightening perspectives. Maggie Karachi is a family caregiver who believes in the importance of family and caregiver partnerships across the Canadian healthcare system and advocates with caregivers across all sectors. In her role as family caregiver, she has learned more about the system, especially the importance of truly integrated, inclusive care, than she has in her 20-plus year career in healthcare. She believes that co-design of patient and caregiver-inspired policies and programs are key to an integrated system that will be more efficient and have better outcomes. She's a volunteer board director at Emily's House, Toronto's only pediatric hospice, and the executive director at the Canadian Association of Health Services and Policy Research. She regularly writes, speaks, and consults on authentic and meaningful caregiver engagement policy and practices. Dr. Nathan Stahl received his medical degree from Western University and completed his residency in internal medicine and fellowship training in geriatric medicine at the University of Toronto. He is currently a research fellow at Women's College Research Institute at Women's College Hospital and is completing a PhD in clinical epidemiology and healthcare research at the Institute of Health Policy Management and Evaluation at the University of Toronto. His doctoral research uses large administrative databases to study the population health impact of caregiving for dementia. His other research interests include drug safety of older adults, sex and gender-based determinants of aging, and healthcare utilization among persons with dementia. His research is supported by the University of Toronto. He has been a staff geriatrician at Sinai Health System since 2017. His clinical work focuses on acute care geriatrics. Dr. Stahl attends on the inpatient geriatric medicine consultation services and on internal medicine clinical teaching units at Mount Sinai Hospital. Dr. Samir Sinha is the Director of Geriatrics at the Sinai Health System and the University Health Network in Toronto, and an Associate Professor of Medicine at the University of Toronto and the Johns Hopkins University School of Medicine. He is also the Director of Health Policy Research at Ryerson University's National Institute of Aging. A Rhodes Scholar, Samir is a highly regarded clinician and international expert in the care of older adults. He has consulted and advised governments and healthcare organizations around the world and is the architect of the Government of Ontario Senior Strategy. In 2014, Maclean's proclaimed him to be one of Canada's 50 most influential people and its most compelling voice for the elderly. Deborah Funk is a mom of 2 adult children. She's been fighting MS for 11 years, which has led to varying complications over the last 5 years, and has been living in a long-term care home for the last 3 years. She's been an advisor for 2 years. She sits on 2 councils and loves to participate in other opportunities when they present themselves, including the committees she's been invited to regarding the pandemic and family presence. She's also recently founded a non-for-profit service organization to help disabled people. Kristen Bruner was born and raised in rural Saskatchewan and lives on a cattle and grain farm near a small city in Saskatchewan with her husband and 2 boys. Kristen has worked for Saskatchewan Health Authority for 15 years as a frontline manager in long-term care, quality and safety, and in her current position of Director of Patient and Family-Centered Care. Kristen has a passion for quality improvement and is a firm believer that patients and residents and families of Saskatchewan are the Health Authority's biggest and most valuable partner. A big welcome on behalf of all of us, and we look forward to learning from the many perspectives that you each bring. Over the course of the webinar, we will take some time to hear from each of our presenters. I'm certain we will glean some really important key insights that will generate great discussions. It is also our hope that you will learn some key takeaways to inform how you can begin and or continue to reintegrate family caregivers as essential partners in care. So we will take some time to hear from our presenters and then move into a panel discussion with 3 guiding questions, and look forward to engaging with all of you in these discussions. Please feel free to use the chat box function to post your comments and questions, and we will address these as we go along. Given our time and the amount of people online today, we will do our best to answer all of the questions. However, if we don't get to all of them, we will certainly send a response following today's webinar. There has been tremendous movement in healthcare over the last decade to better understand and embed the true concept of patients as partners in care. Both CPSI and CFHI have a history of partnering with patients and families to illuminate the value of patient engagement and support pan-Canadian organizations and many other levels within the healthcare system in designing family presence policies from a patient-centric perspective. And that means family caregivers are not just visitors. Instead, they are essential care partners who are often described as family, friend, caregiver, or significant other. They provide support on many different levels, and in many cases, when a caregiver is present, harm is prevented and outcomes and experiences are significantly improved for both residents and staff. We know that when family caregivers are moved further away from the healthcare team, the risks to resident safety are very great. In fact, we know that when family caregivers are present, there is a reduction in medication errors, falls, injuries from falls are reduced, decrease in readmission rates, and there is also a decrease in anxiety and depression. In relation, we see improved discharges, transitions of care, individualized care that includes personalized views of patients. Communication is improved with respect to coordination of care and information. improved patient experience and satisfaction, as well as staff satisfaction and engagement, emotional well-being of patients, recognition of family caregivers as allies and partners in care. CFHI recently discussed the situation of family caregivers as essential partners in care with a rapid response advisory group, and a report titled Better Together was published in July. While the focus of this group is on hospital context, their advice and guidance can be applied across the healthcare system. And so I will just briefly touch on the steps provided. The Rapid Response Advisory identified 7 steps to reintegrate family caregivers. The first, to ensure a foundation of patient and family partnered care. Do you have an organizational culture that believes in family partnered care? Secondly, revisit policies on family presence with patients, family, and caregiver partners at the table. Third, distinguish between family caregivers who are essential partners in care versus visitors. Fourth, consider the needs of people who face specific risks without the presence of family caregivers as essential partners in care. 5, take a comprehensive, balanced approach to assessing risk. 6, establish a rapid appeal process. And 7, increase the evidence to guide decisions regarding family caregiver presence. We are incredibly grateful for this guidance and look to use it as our foundation for further work in long-term care. We are also so fortunate to have Maggie on our call with us today, who also happens to be one of those advisory members. And so, Maggie, on that note, perhaps I can pass things over to you.
Thank you so much for the introduction, Marianne. I'm absolutely delighted to be part of this conversation about finding a new way of working with patients, families, and caregivers. Finding a way that's fundamental to changing the conversation in long-term care in this era of COVID-19 and beyond. And that new way has to move us from seeing caregivers as adversaries, problems to be dealt with, or vectors of infection, to one of understanding, of co-design, of reasonable policy, and true partnership. When I think about why organizing the delivery of care using a new model is so very, very important, why I want to be part of this momentum to change, it brings my mind to my personal why. And if you'll indulge me just for a minute, I'd like to share a bit of it with you. Our family story is a story of what can happen in a fragmented system where care is a noun, not a verb. If I could ask someone just to put up the slide with the picture of my sister and I, that would be great. I'm going to tell people I'm not on my computer, so I'm just on the phone, so I can't see the chat and I can't see the slides. So this is my sister and I on her first day of chemo for breast cancer some almost 6 years ago. She was through the surgery, chemo, and radiation. She had a rocky road during her treatment, and she endured unintended harms along the way. But just when we thought that particular beast was fading into the rearview mirror, she developed some odd new symptoms that we sought help for. It took us more than a year to find out what was going on, but those symptoms led to an eventual diagnosis of a rare appendiceal cancer that required a complex high-tech surgery followed by weeks in the ICU and months in the hospital, with a series of significant complications along the way that have brought us to where we are today. A place where, due to the demands of my caregiving role, my career path had to change, and our life as a family changed forever. She's been a hallway patient through much of this journey. This part's always really hard for me to talk about because in those times she had no name, she had no privacy, and no humanity. She called me one night just sobbing after hearing an overwhelmed nurse yell across the ward, asking her colleague to check on the abdominal drain in hallway 2. She'd become nothing more than a vessel to remove fluid from a body part. Staff were burned out and frustrated and were just trying to get by. They were under tremendous pressure and not to blame. The system, or lack of a system, is what's to blame. As her caregiver, I was the coordinator and holder of her collated story, No one else knew all the pieces. I was the courier delivering radiology images because 4 academic centers couldn't share them. I was the project manager coordinating 5 teams who were like ships in the night while she was in the ICU. And I was the subcontractor trying to arrange home care when the orders hadn't reached them on discharge. In a nutshell, I was an essential part of her care team. I was not just a visitor. When I reflect on our experience, I draw a distinction between treatment and care. Once my sister was diagnosed, she received absolutely world-class treatment, for which we are eternally and truly grateful. But she has not, in fact, received world-class care. I know at my core that a system of healthcare delivery that needed a priority to care for the whole person, with me, her caregiver, as an essential partner in care, would have made a difference. And I want to be part of making that a reality for my sister and for millions of Canadians with similar experiences. We need to make a commitment to do that for residents in long-term care. There's no healthcare yogi dispensing healthcare wisdom to those on the mountaintop. Some answers are right in front of our noses. They're in the valleys where we live, where we work. They're in the lived experience of patients, caregivers, families, and frontline staff. As caregivers, we want what is best for our loved ones. Recognizing caregivers as essential partners is not to undervalue the role of professionals. It is to enhance those roles. I'm here to tell you that we as caregivers are key builders of a new future for our aging adults. We want to be part of what comes next for long-term care, for healthcare in Canada. We know the gaps. We have ideas. We have insights that no textbook will ever give you. And we want to work together for change. Some really great work's already been done, and Marianne's alluded to some of the work that CFHI and CPSI have done, giving really helpful guidance in the Better Together report, where the caregiver voice figures prominently. So what have I learned through our family's experience that are applicable here? I've learned, as Marianne said, far more about the delivery of good health care during my years caring for my sister than I ever did in my career. I've learned that working together differently is not rocket science. I've learned that pursuing health care where caregivers are seen, respected, and treated as essential partners is the only answer to the issues my family and many other families face every day. I've learned that by embracing the ideals of co-design, the work that must be done to build a new system of care for the elderly can be an exemplar of how powerful unselfish cooperation can be. I've learned that we have to change the notion of patients first or caregivers included from being taglines to being concrete ways of designing and delivering better health care. I've learned with tremendous gratitude what is important in life. I hope that you'll come away from today's webinar inspired to fully utilize what I think is among the most underutilized of all health resources, patients and their caregivers. We have to act now to develop meaningful policies for long-term care in the time of COVID, and so this never happens again. The time for sober second thought about no visitor policies is long past. I'm ashamed of what's happened, of how we as a society have let down our elders. For any decision makers and clinicians with us today, in essence, what I hope you take away from my few minutes with you is my heartfelt plea to include caregivers in decision making. Welcome us into your circle of trust. Recognize us as a part of the team. We are your allies, not your adversaries. I told you the story of my sister's illness. My family doesn't have a single Kleenex-worthy crisis event, but rather what feels like a lifetime of small events that piled up one on top of the other, exposing us, making us vulnerable, eroding our trust in the system. and making me as a caregiver feel like a turtle without a shell at times. Each retelling of our story goes my heart anew, but I tell it in the hope that it will help to show that the time for change is now. The voice of caregivers is not simply window dressing. We need to be full participants, equal in all respects to the other partners at the table. To do otherwise brings poverty to the work that needs to be done. There are millions of us across Canada who are ready to make a difference. The momentum I see in the caregiver community has given me hope that my sister and the thousands of Canadians like her will one day truly be at the center of care that is inspired by their needs, welcomes their caregivers, and is designed with them, not for them. And I'd like to just end for a couple of seconds with a note of gratitude for everyone in this virtual room today. I thank each of you for the part you're playing in organizing and leading this transformation of healthcare, specifically long-term care. You make a difference every single day. Your difference is your ability to care, your ability to form relationship, and as a community, come together to solve what has looked to be unsolvable to others. Thank you for being the difference. It matters, and it will help us to shape a new story about the experience of residents, families, and caregivers in Canada and in our long-term care system. Thanks very much for taking the time to share with me today. And I'm going to turn it back over to Marianne.
Maggie, so many positive thanks and gratitude and messages of gratitude in the chat box. You will see a big thank you to you for your insights and for reminding us of the unintended consequences that occur when caregivers are not there to advocate. So Nathan and Samir, this has been an area that you have contributed significant research, and we are looking forward to learning more about the perspectives that you bring. So if I may, pass things over to you at this point.
Thanks very much, and thank you to Maggie for the really, meaningful, poignant, and so important insights that she has shared with us today. And really, I know I can speak for Dr. Sinha that when we do this work, it's on behalf of people like Maggie across the country. So thank you so much for framing the conversation in that way. Today, we are going to be talking broadly about family presence in long-term care during the pandemic. We're going to focus on long-term care, and I'll explain why we're going to focus on long-term care in a little bit. But a lot of the learnings from today can be broadly applied across other congregate care settings, and some of the principles could additionally be applied to other healthcare settings as well. I have no conflicts of interest to disclose. I receive financial support from the University of Toronto through some of my clinician scientist training program and through the Vanier Canada Scholarship, and I'm an associate editor at the Canadian Medical Association Journal, which I receive some income from. I'm going to turn it over just briefly to Dr. Sinha to outline his disclosures.
Thank you, Nathan, and again, a pleasure to be here. And just to note that I do receive some honoraria to be an advisory board member for 2 home care companies in Canada.
Thank you. And just before we begin, a few words about the language that Samir and I will use. We will use, and this is language guidance aligned from those that have been published in the Journal of American Geriatric Society and adopted internationally. We'll use terms like older Canadians and older adults and avoid other terms that may connote negative stereotypes like seniors. And we will avoid, as we do in all other talks, catastrophic terms to describe some of the demographic changes like tidal waves or rising tide, with the recognition that some of that language can actually generate some immediate interest, but actually paralyze long-term action on the topic. And more specifically, when we talk about caregiving, and this is an editorial that I co-authored also in the Journal of American Geriatric Society, we will avoid terms like informal caregivers, as many of you will, or hopefully all of you will agree that really there's nothing informal about caregivers. This suggests casual and unstructured and unofficial care, the sort of opposite antithesis of the sort of caregiving that Maggie described up front. And the terms that we will adopt will be family caregiver or family and friend caregiver or sometimes unpaid caregiver. And additionally, when we talk about those who may be paid caregivers, we will not refer to them as professional caregivers, because that contrasts against the family caregivers and suggests that those who are family caregivers may be unprofessional in their work, when certainly that is overwhelmingly not the case as well. So today we have an outline of 5 things we'll talk about. We'll talk about the epidemiology of COVID-19 in long-term care homes and why perhaps there is so much pushback to reintegrating family caregivers. We'll talk about preparedness and early experiences based a lot on the seminal work that CFHI has done and Dr. Sinha contributed to in a report released just last month. We'll talk about what some of the initial long-term care policy and mitigations responses were, including blanket bans on what they called visitors, which included family caregivers. We'll talk about the devastating impact this has had on family presence. And then we'll review guidance on reopening Canadian long-term care homes, specifically to family caregivers. So I'm going to start by just reviewing some of the epidemiology of COVID-19 in long-term care homes. So long-term care home residents, there's no doubt, are at high risk of contracting SARS-CoV-2, which is the causative infectious agent for COVID-19. This is as a result of the fact that these individuals are in a congregate setting. They are exposed to staff and visitors who may be asymptomatic, or more commonly we're recognizing them to be pre-symptomatic. So they go on to develop symptoms but may be negative when they're exposed to residents of the home and may still be shedding virus at the time that can cause infection. And for many, but not all, residents of long-term care homes, there may be challenges with physical distancing and hand hygiene. We know that 70% of people living in long-term care homes across the country have a diagnosis of dementia. About 90% have some form of cognitive impairment. And this figure at the bottom was taken from the New England Journal of Medicine, which described one of the best described outbreaks in a long-term care setting, actually in Kirkland, Washington State, which had the first COVID-19 death in the United States and the first major outbreak. And it was clear at the time that shared healthcare workers unknowingly, the healthcare workers unknowingly that worked at multiple homes did contribute to the spread of the virus. We also know that not only are long-term care home residents at increased risk of contracting SARS-CoV-2 and going on to develop COVID-19, but they're also some of the highest risk of COVID-19 morbidity and mortality. So many long-term care home residents are of advanced age, and as you age, you develop a phenomenon called immunosenescence, where your immune system becomes less robust. And with advancing age, you accumulate more comorbidities, and some of them like cardiovascular disease, high blood pressure, diabetes, which do tend to accumulate as one grows older, also contribute to poor outcomes. And we've seen what are called case fatality rates, so the number of people who die who become infected within long-term care home settings range anywhere from about 1 in 4 to 1 in 3 that die. We talked about this up front, or Marianne led with this up front, but if you look internationally, Canada has the dubious distinction of having the highest proportion of our country's COVID-19 deaths having occurred in long-term care home settings, and that sits at about 80%. So 4 out of 5 people who died or who have died during the pandemic have died in long-term care home settings. And this data is taken from the National Institute on Aging Long-Term Care COVID tracker, which Dr. Samir Sinha, who will be speaking shortly, led and continues to lead as they track the deaths across the country. I will highlight that, and this was the latest, you'll see it's fallen just below 80%, sitting at 78% of all deaths. But you will notice that two provinces really stand out in terms of the death contribution and the case contribution, and that's Ontario, where Samir and I work, and Quebec. And so Ontario has contributed over 2,000 deaths, and Quebec over 4,600. I'm going to turn it now over to Dr. Sinha, who was involved, as I mentioned, in some of the seminal work done by CFHI in terms of looking at long-term care preparedness and early experiences. And he will likely just briefly turn it over to me as we discuss some work during this time that I published on regarding some of the physical characteristics contributing to long-term care home outbreaks.
Thank you very much, Nathan. And so just moving on to the next slide, what we can see here is that when we think about long-term care homes and their preparedness and their early experiences, this is the CFHI report that some of you may be familiar with. This was just released at the end of July, and we called it Reimagining Care for Older Adults. And this is a report that really, I thought, did an exceptional job really interviewing experts from across the country just to really understand what went well, but also what didn't go so well. And I think what was really important, as Maggie was saying at the very beginning, this wasn't something that just involved kind of experts, if you will. Well, it did involve experts, but those experts were included, both of folks who work in long-term care settings, but also those who receive, or those who have loved ones who are receiving care in these settings, i.e. the voice of, if you will, the family or friend caregiver as well. And I think that was really important because it was helping us to understand things that really went well, but where we actually had shortcomings, such as issues around family presence and a bit of a roadmap moving forward as we start thinking about moving towards concerns around the second wave and how we could prevent some of the missteps that we've had so far and have a more effective response moving forward. We'll just move forward to the next slide. And so really when we see about some of the experiences that we noted, for example, we often talk about some of the underlying vulnerabilities that were existing in our long-term care settings well before the pandemic took effect. And really this speaks to chronic under-resourcing. So just to give you a perspective, if you think about the OECD nations, so these are the rich industrialized countries of the world upon which Canada usually compares itself with, we spend about 1/3 less in providing long-term care. That would be nursing home care and home and community care compared to our average OECD competitors, so countries like England and the United States, etc. And so because of that, because we actually spend 1/3 less on this entire system of care, which is not included under the Canada Health Act, this actually leads to problems in terms of facility design, where we might not be designing or upgrading to make sure that we have the most modern facilities, but also this actually impacts on how we pay the staff. So staff in these settings tend to make far less money than they would if they were working in a publicly funded hospital. And again, most of these homes are publicly funded entities as well. They may be privately operated, but they are publicly funded. And so those actually have implications for people say, well, why do staff work between multiple settings? And partly that's because when staff may be only hired on a part-time basis because it saves the operator money, for example, then in order to make a full-time salary, people work between multiple settings. As you saw, was one of the reasons why we saw a spread of COVID-19 between homes in that Kirkland's, Washington example, and why this was also a big issue in Canada as well. We also know that there is also a rising acuity of the residents. Nathan spoke about how we have a significant number of people living in these settings who live with cognitive impairments, 70% of whom live with dementia. But when you also look at the personal care needs, when you look at the rates of things like incontinence, for example, behavioral issues, and just requiring help with physical needs, for example, mobility, toileting, other things, you find that the overall needs of the residents living in these settings continues to significantly increase, especially over the past decade. I mentioned a little bit about infrastructure, and Nathan's going to talk a little bit more about this in one of his examples. But the staffing challenges, the demographics of our healthcare workers, in terms of appreciating that when we're hiring people into these settings, this low-wage work tends to actually go to racialized women who may not be given other options for employment as well. So we're often building an entire long-term care system on a very unstable footing, and in a footing that, for example, when we're not paying people well and we're not treating workers well, it's no surprise that 80% of homes in Ontario, for example, were having trouble recruiting people to work in long-term care settings, and while there's also significant retention issues. And as Nathan pointed out, Quebec and Ontario, the hardest hit provinces, the Ontario Long-Term Care Association estimates that Ontario lost up to 50% of its actual usual workforce from the start of the pandemic, and Quebec itself has quoted numbers that they've lost over 10,000 workers, and so they're now trying to recruit new workers to come and work in the system with a significant pay raise, but I'm not sure how successful that's been. So we also know that many people who were actually working into these homes or coming into these homes as visitors, or whether they were providers, there were challenges with limited infection control measures, for example, and we saw that right from the beginning there was challenges accessing PPE, challenges with implementing guidance, and that also included training and practices to make sure that the staff who were working in these homes were well trained and well supported to even know how to use the PPE that they had when it was once available. And then we also know that there's significant challenges in terms of medical direction practices and responsibilities, and this is something that exists across long-term care settings, but also into other congregate living settings like retirement homes, group homes, etc. So a lot of challenges, if you will, that really didn't set our long-term care system for success, and why, as Nathan was reporting, that Canada has that dubious distinction where 80% or so of its deaths have occurred in these settings, and mainly because when we see other countries that have done particularly well, like Germany and Austria, for example, we have found that actually, instead of actually not addressing these issues, many of these issues weren't issues in those countries, and in fact they made sure that their homes in these countries had ample PPE, had access to improved training and support to really make sure that we protect the vulnerable people in these settings. We'll go to the next slide. Nathan, would you want to talk about, this is your work, so I'd like you to talk about it, please.
Yeah, so one of the things that has really come to light has been the facility and structure issues. This was work we published just last month in the Canadian Medical Association Journal. And just to highlight sort of the many issues that Samir has outlined in terms of contributing to setting up the sector for really having the really horrific COVID-19 outcomes we saw. One of the things that had come to the surface was whether for-profit entities had performed worse when it came to COVID-19 outbreaks. And these are actually, if you look at the y-axis, is the proportion of residents with COVID-19 in long-term care homes. And on the x-axis is the profit status. And all the little, each dot or triangle represents a home. And so the higher you get up on the y-axis is the larger the outbreak. And so we found that, homes, the for-profit status of a home did impact, and there were more for-profit homes that had larger outbreaks. But really, when you looked at which of them, because there are many homes down at the bottom that had no residents, or a very small number of residents that had COVID-19 outbreaks, what really came to light were the homes that were older design standards, ones that had multiple shared rooms with multiple washrooms that allowed the virus to rip through facilities when they got in. And a lot of the ones also had to do with the ones that were chain ownership. Again, speaking to some of the other vulnerabilities, we know that homes with chain ownership tend to have lower staffing levels. And additionally, there may have been more sort of regional oversight of homes as opposed to direction within a home that may have been needed during these times of crisis. And similarly, when it came to, when you look at the proportion of deaths within a long-term care home, so those who died of COVID-19. Again, some of these systemic vulnerabilities in terms of homes that have older design standards. And when we're talking about Ontario here, these were design standards that meet or fall below those set in the year 1972. So we're really talking about outdated facilities or homes when it comes to the ones that have older design standards. And we've furthered this work, again using Ontario nursing homes. And we've looked, okay, let's move beyond the for-profit status and the older design standards and look across all sectors at what we called crowding. And when we look at crowding, we're talking about the average number of residents per room and washroom. And we saw, if you look here, the bluish dots are the cases and the orangish dots are the deaths. And you see a clear relationship between more crowding on the x-axis and the incidence of cases and the incidence of deaths. And this sort of work, preliminary communication of this work, has led in a province like Ontario to actually restrict new admissions to no more than 2 residents per room. So this is just to show some of the infrastructure and facility risks in sort of a deeper dive in Ontario, but certainly many of the other factors that Samir highlighted were contributors to the vulnerability in the sector. I'm going to turn it back to Samir to talk about some of the other learnings from the CFHI, CPSI report on long-term care homes.
Thank you, Nathan. So in terms of this slide here, we were talking about some of the initial pandemic preparations focused on that a lot of that work here that happened in Canada focused on preparing our acute care hospitals, because I think largely when health officials here and the public were watching how COVID-19 was affecting other European nations, we certainly saw images of overwhelmed hospitals, and I think largely assumed that overwhelmed hospitals meant that the knock-on effect, if you will, is challenges getting care for people living in congregate living settings. And so a lot of focus, I think, was initially being focused on preparing our acute care hospitals to be prepared. But we found that in other countries like Belgium, where this exact same situation was happening, what was more horrific in the end was that the hospitals, just like in Canada, were never overwhelmed in the end. And in fact, that many of the care homes really were left unsupported, and in many cases, unfortunately in Belgium, individuals were not even allowed to, residents were not allowed to even access acute hospital care, which was felt to have hastened a number of deaths. So there was a lot of things happening, but in terms of some of the findings from the report, a lot of long-term care homes felt that they were being talked down to by health system leaders, that health system leaders that may have been more familiar with acute care hospitals and more well-resourced organizations may not have been aware, for example, of how the long-term care system or retirement homes and group homes work, how they're operated, their philosophies of care, that these aren't facilities, these are actually homes. There's a lot of confusing, unclear, and conflicting communications that were occurring. There was also a lack of public and timely reporting of data. So there was actually really challenging issues in terms of even if deaths were being recorded, as COVID-linked deaths early on in the pandemic in homes, how that data was being reported. In Ontario in particular, we had significant data issues where there was always reporting about what was happening in nursing homes, the 626 nursing homes in Ontario, but there are 770 retirement homes that were barely getting any mention, even though there were hundreds of outbreaks and many deaths that occurred in these settings as well. And the challenge was that early on in the pandemic, a lot of that PPE, personal protective equipment distribution, but also expertise around infection prevention and control was not necessarily being deployed in a timely and effective way to these settings. And so, of course, every province you see slightly different variations and themes. We often highlight in the report the success that happened in places like British Columbia, in particular as a province, or even the Kingston area in particular that was quite proactive on a number of these measures to show that there were actually some areas of tremendous success. But overall, while resources and attention were only shifted to long-term care settings in general once the catastrophic outbreaks were reported. And then you saw what was happening, especially in places like Ontario and Quebec, where then the immediate responses were trying to get hospitals to get involved in terms of redeploying their own staff. And I know my colleague, Dr. Stahl, was particularly involved as a physician, an acute care physician, supporting a particular long-term care home in Toronto that had been quite devastated in terms of providing geriatric medicine support. But we often not only found that hospital staff, nurses, physician supports were being redeployed to help out, but in Ontario and Quebec they also started compelling school board employees and eventually had to bring in the military to help out with a number of homes in Quebec and Ontario. And of course a number of redeployed human resources were found to have little or no experience working in long-term care settings, which also created tensions in terms of understanding that these aren't, while these are settings where care is being provided, these are first and foremost people's homes. So a lot of early experiences that allowed a lot of lessons learned, but an opportunity to obviously rethink about what happened and how we move forward. We'll go to the next slide. So Nathan, I'll turn it back to you.
Sure. So one of the things that we also wanted to briefly touch on, and I know we can't touch on everything in the limited time, and there's some other important people that need to speak here today, is that one of the things that Dr. Sinha's team led was what happened in Ontario and across the country in terms of some of the responses that governments and health authorities took to protect older Canadians in long-term care and congregate settings. And so, Samira, I would just ask you just to talk briefly, as this is now moving into our focus on family presence, what was largely done across the country as a sort of knee-jerk response, which included shutting out family caregivers?
Yeah, so very briefly, the key is that with a lot of the actions that people are very familiar with, one of the early decisive things was just to restrict all non-essential visits, which really eliminated a lot of the family presence that was occurring in homes. Other things like we've mentioned about limiting staff from working in multiple locations, making sure that there's access to PPE and proper testing protocols, and even the creation of flexible admission and discharge policies were other moves that were being made. But we really saw a delay between the restricting of non-essential visits and then the reopening of homes that occurred only more recently as well.
So, I'm just going to show this in pictures, sort of like Maggie has showed, just from across the country. This will be not unfamiliar to anyone, but what impact did this have on family presence? Well, we took people who were experts in caregiving and in providing care for residents in these long-term care homes and other congregate settings, and we put a barrier between them. This is a photograph from Winnipeg. The window visits became a really, I don't want to use the word iconic, but perhaps notorious image during the pandemic. In Toronto, someone went so far as to rent a bucket crane because obviously window visits can only be done by those on the ground level. This is a photo from Barcelona, Spain. We've seen hugging curtains, and we'll talk briefly about hugging, but the sort of contraptions that would, if you showed this to somebody a year ago, would seem completely bizarre and fictional. And then, of course, images like this from Quebec of isolated and lonely older adults looking out the window to the world outside of them. And so really what grew out of this or what continues to grow out of this is concerns about what French long-term care physicians defined as the confinement syndrome, which they questioned in a letter to the editor in a journal of whether the adverse impact of isolating older adults like this, whether the morbidity and mortality associated with that, as they dubbed the confinement syndrome, actually was worse than COVID-19 itself. And so, we talked, I think Marianne talked about unintended consequences, and I would push back and argue that these are not unintended. We know that this is happening. These are collateral damages of what is going on. I think our decision makers are using the word unintended, but this is in no means unintended, that there is a risk and a balance here to this blunt public policy that's being imposed. And the collateral damages that we are seeing from this confinement syndrome are extreme. We are seeing dehydration and malnutrition. So on the right, this was a terrible news story out of Toronto where the death certificate or the coroner's reports deemed that the individual had died of malnutrition and not COVID-19 from living inside a long-term care home and not having access to family caregivers. We've seen physical and functional decline. There's been a lack of access to some medical services, so chronic medical conditions and mental health disorders have deteriorated. People have had cognitive decline and delirium. We've heard cases across the country of families, being reunited with their loved ones who have deteriorated so much cognitively that they have not been able to recognize their loved ones. Worsening of responsive behaviors. So there's been anecdotal reports of increased use of psychotropic medications and physical restraints because the behaviors of people living with dementia have worsened during this terribly difficult time. Loneliness and social isolation have been the other pandemic that has been going on, and of course psychological distress, depression, and anxiety. So the collateral damages of this so-called confinement syndrome are extreme. And so what we saw, and particularly on the heels of the really important CFHI report on providing some guidance for reintegrating family caregivers into acute care settings, was that provinces and territories across the country, I would say in late May, early June, were starting to develop some guidance and put out guidance on reopening Canadian long-term care homes. And what we saw during this time was that this guidance, even in light of the accumulating evidence on confinement syndrome, even in light of the accumulating demands across the country for family caregivers to be let back in to provide the care that they knew they were experts at providing for their loved ones who lived inside these settings, that it still wasn't striking the right balance, that it was still remaining overly restrictive, that it was still not providing particularly family caregivers the access they needed. And so Samir and I, with infectious disease experts at our institution, and with other health policy experts that work for the National Institute on Aging associated with Ryerson University, and most importantly with the expert review of over 50 people across North America who are experts as family caregivers, infectious disease doctors, or long-term care physicians or administrators, provided an expert review of a document we did, which is now published in the journal JAMDA, which we strove to develop guidance that really struck a better balance. And so I'm going to talk about this and certainly delve into this more in the discussion. But we outlined 6 guiding principles, again, based on what we heard and based on some of the work from CFHI's reports. The first thing is that policies, and they still largely across the country, do not, but they must differentiate between who's a family caregiver and who's a general visitor, and that residents and substitute decision makers and their families should have the authority and autonomy to determine who is essential to support them in their care. And so we need to understand that some people are there not just as visitors, but are there to provide direct care. 2, we talked about that the restricted access to visiting must balance the risks of COVID-19 with those risks of the confinement syndrome, and that there must be a better balance here. Thirdly, that the policies that are being created and implemented should prioritize equity over equality and be both flexible and compassionate. So equality would mean giving all long-term care home residents the same access to visitors, but equity is about giving long-term care residents the right amount of access they need to maintain their health and well-being. And so that might mean giving some residents more access than others based upon their needs. 4, and I think we've struggled here, is that governments, public health authorities, and long-term care homes need to provide regular, transparent, accessible, and evidence-based communication about what's guiding their visitor policies and access to visitors. And I do not like the term visitors, but there needs to be some singular term to refer to everyone who's trying to enter the home that are not residents, which is, we showed above, include family caregivers and general visitors. 5thly, robust data related to reopening long-term care homes to family caregivers and general visitors should be collected and reported. And this speaks to the fact that one of the things that the decision makers are holding over everyone as fears in all this is that if we open up the doors to family caregivers, we're going to reintroduce virus, and that's a non-starter. And 6, there needs to be a mechanism for feedback and a process for rapid appeals, because family caregivers across the country are feeling that homes are shutting them out. They may be even violating the guidance which has been set out by public health authorities or governments, and they have no recourse or action to be able to take up these issues with that simply the answer from the home is no, and they're being left on the sidelines. And so briefly, our last 2 slides before we hand it over and certainly I know this is small, and this guidance is available online through the National Institute on Aging and also through the open access publication in JAMDA. And additionally, we know that the slides will be posted. But for family caregivers, it's really important. We did a scan from across the country of what visitor policies were across all the provinces and territories, and we looked internationally as well to provide input into this. And we tried to develop some guidance that would be more reasonable. And importantly, you'll see that we have separate guidance for family caregivers and for general visitors. And for family caregivers, again, we need to define and recognize family caregivers, and that power we think should be within the hands of the residents or their substitute decision makers. And that because once you put it in the hands of homes or government, it can be very difficult to either quantify or qualify who meets the threshold in their eyes for being a family caregiver, and residents themselves should have the authority to determine who's essential to them. We feel that that residents should be able to designate at least 2 family caregivers so that it doesn't fall on one person who is usually a woman, because we know that women tend to assume the majority of family caregiving responsibilities. We think that family caregivers should be allowed in the home, which you'll see is different to the large part than general visitors, and should have access to the home even during outbreaks. So some of the extraordinary things that had to happen, including calling in the Army, may not have had to happen if family caregivers were allowed in to support residents during this time. And then, they should have access to the same PPE and IPAC training as staff in the nursing home have. And in contrast, if you look at general visitors, so we've actually, we're going to hear from people from the Saskatchewan Health Authority shortly, but we thought that their guidance was very reasonable and flexible when it came to general visitors. In terms of outdoor visitors, which can include more than 1 visitor at a time, providing that physical distancing can be maintained, and that even that family members from the same household and or bubble should not have to physically distance from one another. We've seen in Ontario that they've restricted it to 1 individual coming, even though a whole family, so I can speak for myself, wanting to see my grandmother in a retirement home, I'm not able to come with my wife and my 2 kids, despite the fact we're all in the same household. And then, outdoor visits we think should be prioritized when possible and feasible, because we think that actually minimizes the risk, or we know that minimizes the risk of transmission. But we need to be flexible and compassionate here, realizing that won't work for everyone. And then, masking makes a lot of good sense, as is being, as has been seen across the country, so they should remain masked and physically distanced. But we recognize here for people who are living in these settings that, physical contact may be something that is desired by some residents or needed. And so when it comes to things like hugs and hand-holding, these things should be considered as long as they're brief, and hand hygiene is performed immediately before and after. So I know there's a lot of details here, and we really made this as prescriptive as possible to be able to provide this to decision makers. And we've actually seen that in Prince Edward Island, they've actually adopted policies drawn a lot from the work that we've done, which has been really validating. We hope that can be similarly done in other jurisdictions across the country. So with that, I'm going to hand it over back to Marianne. Sorry for going slightly over time, and we'd be happy to follow up on a lot of the stuff we've touched on in the discussion portion of this webinar.
thank you both so much. Such amazing information. I believe you gave us a lot to think about. And just before, I'm just looking through at the chat box, and there are some themes in there, but they are in relation to some of the guiding questions. So I'm just suggesting that we move forward, and then we will answer those questions as we go along through our panel conversation. So again, thank you so much, and I invite Kristen and Deborah to share your insights with all of us. Thank you. Over to you.
Hi, everyone. Thanks for having us here today. And thank you to the speakers who spoke before us. Thank you, Maggie, for sharing your story on family care, on being a family caregiver. So I was asked to share a little bit about the journey here in Saskatchewan with family presence as it relates to long-term care. So much like you who are on the call today, in March and April, what we experienced in Saskatchewan was a public health order that spoke to no visitors within any of our facilities, acute care or long-term care, except for compassionate reasons only. And what we found was that compassionate reasons was really being interpreted as end of life. So just like Dr. Stahl spoke about, we had essential caregivers that were removed from our homes in March and April. We did have virtual visiting and window visiting, much like the rest of Canada, but it only works well for a small percentage of our residents and lends itself more to the visiting aspect, not necessarily the family caregiver aspect. So in early May, we pulled together an expert panel. We have patient family advisors from across Saskatchewan and leaders from across the Saskatchewan Health Authority, and we took a look at the compassionate care guidelines and what that meant. So we were under the public health order from our ministry that spoke to compassionate care reasons, but we were able to update those within the Saskatchewan Health Authority. So for long-term care, what that meant in May and through June was that those residents who needed family presence for quality of life or enable for their needs to be met could have a designated family support person. So we worked through that, and as you can imagine, quality of life is very hard to define and is only defined by the person living the life. So we, what we did at that time to help our staff and our leaders and our family is we put together a support team. So we called ourselves the Family Presence Support Team, and we were an intake line through email, just helping various folks decipher what those compassionate care guidelines were and really promoting, starting to bring family support caregivers back into the long-term care homes. Then we really realized that we needed a change to our public health order to really start embracing family presence back into the long-term care homes. So we wrote to our Chief Medical Health Officer asking for a change to the public health order to have 2 designated family support people per patient and long-term care resident. And he had approved that, and we had a change to our public health order at the beginning of July. So where we stand right now in Saskatchewan is we have a policy directive on family presence that's endorsed by our Ministry of Health. Each long-term care resident is able to pick 2 family support people, with only 1 being present inside the building at a time. That's what we're currently working with. We also have outdoor visits happening to promote the visiting aspects of things, so not necessarily for providing care, but for families to be able to come and have that social opportunity with their loved ones. So the outdoor visits are going really well here in Saskatchewan too. And what we're finding is that there's varying levels of family presence throughout our organization. So we are the entire province of Saskatchewan. We are a small province people-wise, but we do find a lot of variation happening with family presence throughout our homes and our facilities. Some of the struggles and the barriers that we found with reintegrating family presence back into our homes was the fear of COVID-19 coming into our long-term care homes. I think all of us could turn on the news and see what was happening in long-term care, and staff, residents, families, leaders were worried. We were worried about having folks come back in when we essentially had the iron ring up. Managing the screening process has also been a challenge, being able to staff that, have proper screening of the folks coming into our long-term care homes. Another barrier, I would say, is the constant change. So as you know, from March, so many things have changed, and constant updates and changes to policies and the learnings that are going on just with COVID in general. So, you know, staff, families getting fatigued maybe with all of the changes that are happening. And another one I would say is managing social distancing within the homes and between the family caregivers, and also proper PPE. So Dr. Stahl spoke to proper education for using PPE for our family caregivers is something that we're currently working on. So just to wrap it up, going into some of our future work in the next month or so, we're looking at those 2 designated support people and what's the ability to change those support people given caregiver burnout, caregivers going away for an extended amount of time. We're also drilling down on the frequency of family presence. So we said that each resident could have 2 family support people, but what we're finding is that each home had the opportunity to operationalize that. Some were able to have, you know, endless hours, and some weren't. Some had to schedule it in order to maintain social distancing, screening, and all of those other things. So really starting to drill down on the variation that's happening in the frequency. And also thinking about family presence during a pandemic and what are the long-term solutions. We know that this isn't something that's going away by the end of the month. So how do we keep a constant focus on family presence as we work through this pandemic for the long haul? And of course, we live in Canada and outdoor visiting only works for so long. So that's something too that's on our mind is, well, how are we going to take the concepts of outdoor visiting and that need that it's fulfilled for that social interaction when it's winter or even fall, it gets really chilly here. So that's something that's on our mind too. So that's just a little bit about what we work through here in Saskatchewan, and I'm going to hand it over to Debbie, who's a patient family advisor. And Debbie has been working with us in our expert panel since the beginning of May, and I'll hand it over to her to share her thoughts.
Hi everyone. Yeah, it's been great working with the expert panel and all the other things that I've been able to do. But it has been a huge challenge living here. I'm one of 2 people in my neighborhood in our home who doesn't have dementia. And the only way that I can phrase it is that my neighbors here are very generous with their germs. They don't understand physical distancing and that sort of thing. So I tend to spend about 99% of my time in my room with my door closed. Couldn't do window visits because I'm on the 2nd floor. So it's been just webcams, and you know, so when the outdoor visits were allowed, it was exciting because actually the first week of outdoor visits was also my daughter's birthday, so I was very excited to get an outdoor visit and share some birthday cake with her and that kind of thing. But it's been a very, very long time that I've been in my room, and it's starting to feel more prison-like, for lack of a better term, because I just don't know when I'm ever going to be allowed to go out again. I'm an auntie to 14 people, and I'm the youngest in my family, so I'm quite close to the age of my nieces and nephews. And I've always been, you know, we would always go to the park in the summertime. We would always go have movie days, and I haven't been able to see the extended family very much. I have MS, and so the outdoor visits aren't very good when it's been so hot out. We've had a bit of a heat wave, and with the heat, I can't be outside, so I can't have visitors. So there's been challenges. The staff has been great, working really hard to try to find activities and do fun things, but they're very busy and often short-staffed. And so as much as everybody's been working together to try to make this the best that it could be, it's still been very, very difficult. And, you know, with hearing that long-term care homes may not open until next June, it's been kind of depressing, really, to not know when the end is coming and when there will be some kind of normalcy. With indoor visits, I had to choose as well. I have 2 children and my mother who wanted to come see me, and my son very graciously said that it was more important for Grandma to come and see me than him, so I had to choose my mom over my son, and that was really difficult too. And then we had to have meetings and try to figure things out because my daughter works during the visiting hours that are allowed, so we had to have some kind of stressful meetings and decide whether or not they could extend the hours so that she could actually come and visit. And so as much as there has been good and positive things, there's also been a lot of stress and strain on relationships and that kind of thing as well. And Kristen, do you have anything to add?
I don't. Thanks, Debbie, for sharing.
Thank you both so very much. We really appreciate hearing your perspective, Debbie, and understanding the real impact this has had on you and how others are experiencing this firsthand. We are grateful for you sharing your perspectives, and we're also thankful that you're in such a great situation to bring these concerns to the committee you are working with to support all of these very necessary improvements. Kristen, we know operators are trying hard to balance that need, and we thank you for identifying all the barriers that operators are facing right now. And I think that's a really good segue into our panel discussion. And so, as mentioned, we have set up 3 guiding questions, and that will ask our panelists to answer, and then open up for comments and questions from all of you. So we'll start with our first question. What are the barriers encountered for reintegrating family caregivers? And Kristen, you started us off with a great list of those barriers. I wonder if in reflection you have anything that you wanted to add there, and then perhaps we'll pass it on to Samir for his comments.
Yeah, I think just adding to, the fear and the unknown, I would say is probably the biggest one, and being really hesitant about welcoming people back into the long-term care rings after having what people refer to as the iron ring of safety, or what they felt was the safety around those homes.
Mm-hmm. Thank you for that. Samir, did you want to add anything there?
No, I just want to, I think we've talked a lot about some of the barriers that people are encountering, and I think it's this tension that exists between, guidance that's not 100% clear, homes that, genuinely want to support the reintegration but are worried about safety, liability. They don't want to do the wrong thing, and I think similarly with politicians, the Minister of Health, doesn't want to say, well, was I reckless? And I think, one of the things that is important, that a number of the long-term care acts that exist, they talk about the rights of residents, and say the resident, like Deborah has the right to receive visitors. At least that's what the Long-Term Care Act in Ontario does say. So when does the rights, when do her rights no longer, when does safety trump her rights to have visitors? But it's also not only thinking about, rights, or Deborah's rights to accept visitors, for example, but also what about the rights of the other residents there who might say, well, if Deborah's family comes to visit her and they give her COVID, could that put us at risk? So I think what's been very interesting is how much this pandemic has really uncovered a lot of things where a lot of family caregivers were kind of hidden care providers and supports in many of these home-like settings, and now all of this is out there to the fore, and I really think we need to give these issues as much priority as we have been about how do we prevent COVID, but also how do we really support family presence, because we just heard from Deborah's example about how important this is between choosing your son versus I can't even imagine what you just went through, which is one of those many examples you shared with us.
Thank you for that. And I'll just see if Maggie and Nathan have any comments.
The only thing I would add is that I think one of the barriers has been a lack of evidence. So based on that fear that we've talked about and the fact that COVID-19 was such a new, novel virus that we just didn't know how it was going to work, that may sort of led us to this blunt instrument policy that now is a barrier. So I think we need to start thinking about the evidence. So is there evidence that family caregivers are vectors of infection? And if so, how do we address that? So, in my mind, those are some of the barriers that still remain.
Yeah, and just to follow up on what Maggie has said, we do know from there is a piece of evidence we are aware of from the Netherlands. I can share it in the chat box, where they reopened their nursing homes, 26 of them, to family caregivers, and didn't see a single new case of COVID. And based on that initial evidence, expanded that across their country. One of the things I think is a big barrier here is that we have to recognize, as has been highlighted by Kristen and others, that homes are in a very different position now than they were back in March or April. And there's no doubt when we saw it in Kirkland, Washington, and we've seen it in other settings, that the family caregivers probably were a vector, as were staff, for COVID-19. But we're in a very different place now in terms of preparedness of homes, recognition of the asymptomatic or pre-symptomatic transmission, securing access to personal protective equipment, having robust IPAC policies in place. And, we didn't respond when staff became vectors or were vectors for COVID-19 by throwing them out of the home. And I think it reflects the general barrier that we see family caregivers as a luxury or as a bonus rather than something essential, because the response to them has been, well, they may have been a vector and they could still continue to be a vector, and so we're just going to keep the doors closed to them. So I think it's that failure to recognize, as Maggie let the talk off, that family caregivers really are an essential part of the healthcare team, the same way that the staff who work in these homes are. And I saw through the chat box as well, and we've heard this as feedback from our guidance, that homes, the governments across the country still haven't addressed many of the chronic deficiencies, some of which will require more resources to reintegrate family caregivers. So we need to address staffing shortages, and we need funding for the PPE that may be necessary to reintegrate family caregivers. But that shouldn't be an insurmountable barrier. That is something that must be done to support what is a necessary and essential reintegration.
Mm-hmm. Thank you all. I think those we really appreciate hearing the multiple different perspectives when it comes to the barriers to reopening long-term care homes, both from an operator's perspective, residents, families, as well as system perspective. And so just a quick note, I recognize all of the commentary going on in the chat box and a lot of passion. And I see folks answering each other's questions as well. But what we will do is we will commit to reviewing the chat box. If, for example, we don't get to all of the questions, which I imagine we likely won't, given the time we have left together, and we will commit to getting those questions back to all of you in a document for all the participants that were on the call. So rest assured, if you did put questions in there, we will certainly answer all of them. So maybe what we'll do is we'll move on to the second question, and we'll address those. And then we'll see how we're doing for timing, recognizing we have about 12 minutes left together. So with respect to our second question, what can we do differently in order to recognize the role of family caregivers as essential partners in care? And Maggie, perhaps I can start with you, and then Nathan, to you for some thoughts, and Debbie, too, if you have some thoughts, that would be lovely.
So thanks, Marianne. I think this is a really, really important question, and it comes back in my mind to a couple of things. So one is that differentiation between a family caregiver and what our role is and that of a visitor. So making sure that those distinctions are clear. And the other thing I'd say is recognizing that as a family caregiver, there is nothing more important to me than protecting my sister, than doing what's right. And if that means, in the case of COVID-19, learning about how to properly use PPE, working with an institution to understand what is allowable and not, and how I can be welcomed back into that institution. I am motivated to make that happen, and I think all caregivers are. So recognizing that, that we want to do what is right and we want to protect our loved ones. And I think the third thing that's really important, because one of the things for me over COVID-19 that has been kind of an epiphany is the fact that caregivers that I thought were embedded in the system more solidly, as it turns out, are not. So I think we need to be sure that we have the infrastructure in place so that when this or anything else happens, caregivers are at the decision-making table. They're part of the policy development. They're part of those conversations so that we don't have to go back and correct, that they can be part of making something reasonable and workable happen right off the bat.
Yeah, just very briefly, I don't have much to add, but I think, COVID-19 has illuminated many, injustices across society, and I think one of them, to Maggie's point, is that I think often not CFHI or CPSI, but often lip service is given to patient and resident-centered healthcare systems, and we're really seeing that those are the first things to go when a crisis hits. That I think much of our healthcare system give lip service to that rather than really integrating them. And I think the second thing is, COVID-19 has shown also the extreme crisis in staffing. And I'm not suggesting in any way that we should download these staffing shortages onto family caregivers, but there's a real value proposition for homes and decision makers that, you are actually not only would you're actually exacerbating the staffing crisis that you're having in long-term care, because now tasks that were normally done unpaid by family caregivers are now going unfulfilled and requiring extra staffing. And so, when I think about the minds of government or decision makers in terms of a value proposition, that could, and the fact that we're not going to be able to fill in the staffing shortages that are recommended anyways in the short time period before successive waves may hit, that seems to be a no-brainer to me.
Thank you, Nathan. Debbie, over to you for any thoughts here at One Chair.
I don't really have much to add, just that, defining essential partners in care is very, very important, because I think sometimes the clinician definition of essential and a resident's definition of essential can be very, very different.
Mm-hmm. Absolutely. Thank you for that. And we'll move on to our third question. While integrating family caregivers as essential partners in care to support residents, what solutions might you recommend to support seniors care operators? And Kristen, perhaps I can start with you, and then Maggie and Samir.
Sure, thanks. I hope you can still hear me. I seem to have lost connection on my computer, but yeah, I would say that one piece that's been really valuable is having our family present support team. So it's honestly just a generic email address that we created that's manned by some of our team members, and we are basically just there to help answer questions, work through concerns, work through scenarios. We have actually had a couple of family appeals come forward too, where families were not happy with the outcome that was given to them in their request for family presence, And it's also an opportunity to educate the leaders, staff, managers on, the changes in family presence and the need for family presence, and really be an advocate for it. So I think we've had that going. We're in our second month of our family presence support team now, and we're still just as busy as we were on day one. So I feel like that's been one of our keys.
Great. So, so I really have very little to add other than, I think having open communication is so important, and having it two ways, so between the operators and caregivers, as opposed to just, we heard a lot in Ontario of, we've got a directive from the ministry, from government, there's nothing we can do. So I think, that model of having conversations with your caregivers is a really big part of the solution.
So critical, communications, absolutely. Samir, over to you for your thoughts.
Yeah, I think the just to add on to everything that's been said so far, I think really we're talking about good quality communication, as Maggie was saying, right at the level of the home, because I think a lot of the guidance out there is kind of at the minimum, and it shouldn't be seen as kind of the ceiling. It should be the opportunity to say, well, what can we do to really promote good, safe and high quality visiting? And where we are seeing barriers, like our colleagues in Saskatchewan were saying, some homes have enough staff, they have enough capacity to facilitate all the visits that need to occur. Others are really struggling. Well, if people are struggling, what's behind that struggle? Is it a lack of personal protective equipment? Is it a lack of staffing? How do we outline what those barriers are so that we can focus on what those solutions can be? Because sometimes there can be creative ways, for example, in which we might be able to streamline some of the processes to make it easier and more efficient to support visitors. Just better communication, and I think these are some of the things we need to do. I think the challenge is that it's easier just to say, you know what, this is too hard to do it. We're not getting the resources, so we're not going to do this. And at the end of the day, we've got people like Deborah and her family, and so many hundreds of thousands of others in the situation across the country who are just being caught in the middle, and they don't have time to wait for us to figure this out. We need to make this a clear, equal piece of work that we need to do, because as Nathan was saying back in our presentation, we're seeing more people who are succumbing, unfortunately, to other things than just purely to COVID-19 itself. And that's the real tragedy here, that when we don't actually give credit to the role that family caregivers and others really do to promote the well-being of those who are in residential care settings as well.
Thank you, Samir, for those last comments to that question. I just want to thank you all so much for this vibrant discussion. I know we've certainly taken away a lot of these key messages for how best to support the continued work to galvanizing the role of family caregivers. So just recognizing our time, we will close the panel discussion and remind everyone once again that we will certainly respond to answers in the chat that we didn't get a chance to respond to. So thank you for your active participation. We certainly see a lot of commitment and passion across the chat box as well. So just a couple of more slides to share with you. So as I mentioned at the onset of the call, CFHI and CPSI have launched a new program called Long-Term Care Plus, Acting on Pandemic Learning Together. In addition to the virtual learning series, a self-assessment tool is now available. So leaders, managers, direct care staff, and patient family representatives are encouraged to complete the assessment together. The tool can be completed and submitted by an individual for the long-term care retirement home. If not already, I'm sure my colleagues have shared links in the chat box. The tool is also available on CFHI's website and will be launched and will be also included in a follow-up email tomorrow to all of the participants. You can now, an online portal is also now live. You can now register to participate in the different program offerings, so long-term care huddles, coaching, an opportunity to receive seed funding. Those details also are available on CFHI's website. And while we have your attention, please do let us know in the chat box if you or your home are planning on applying, and if there are any additional information you are looking for that we could help in terms of making that decision. Next slide. A reminder for the next event, August 27th, there will be a long-term care huddle. Please register to attend via the online portal. September 14th, join us for a webinar with Dr. Kieran Moore, who will share Kingston's experience and strategy used to prepare and prevent outbreaks in the long-term care facilities since March. Any questions, please feel free to email us at the contact information provided. And just before we launch the poll, I would like to especially thank, as I said, our dynamic panel for their insights and guidance and continued support as we aim to improve family caregiver policies in long-term care and retirement homes, ensuring we take these lessons learned and expert advice and use it to improve the quality of life for seniors in Canada. So thank you on behalf of all of us. And just a couple last polling questions for all of you. Overall, I was satisfied with my webinar experience. I know more about family presence in long-term care than I did before participating in the webinar. The webinar has provided me with ideas of concrete next steps to re-engaging families, caregivers as essential partners in care. And lastly, we are always interested in looking for improvements in how we deliver our webinars. So if you have any comments or suggestions, please feel free to share that with us as well. So thank you on behalf of the Canadian Patient Safety Institute and the Canadian Foundation for Healthcare Improvement for joining us today.
Ladies and gentlemen, this concludes today's conference call. Thank you for participating. You may now disconnect.